Okay, good evening, everyone, and welcome back to our Paediatric webinar series. I'm very excited this evening because we have Dr. Syed with us, who's going to be delivering a talk on fever and rash. But for the doctors amongst you, we first have a quick message from the BMA. We're joined by Daniel Tyler, who's just going to talk to us shortly and tell us about a little competition. So over to you, Daniel.
Thank you. Hi everyone. Sorry, this is only really relevant to doctors and med students. But yeah, I'm from the BMA. I work with sort of the juniors and students in the London area, essentially making sure that everyone's getting the most out of membership and sort of providing help and support to members. So yeah, you would have seen there should be a link in sort of where you're watching from, correlating to sort of what's on the screen at the moment, so the QR code. So yeah, this is the first Mind the Bleep I've come along to so far this year, and I will be at a few more, but not all of them. So yeah, so just quite excitingly, one of you watching the Mind the Bleep sessions will win a £100 Amazon voucher. All you have to do is follow that QR code on the screen. So hold your phone up with the camera, and it'll bring up the link, or use that link that's in the chat, and you'll enter into the £100 Amazon voucher prize draw. So yeah, this is only available to sort of Mind the Bleep sort of attendees where I'm coming along. So I would say the chances are quite high. So yeah, so if you're a med student or doctor, enter. There's no catch. You're not signing up to membership. It's just a way for us to keep in touch with you and give you some sort of some like helpful emails. And yeah, it doesn't matter if you're a member already or not at all. Just it's for everyone to enter. So yeah, just for taking part as well, you'll get a free junior doctor employment guide. So again, it doesn't mean you're signing up to membership. It's just a free sort of support pack from us to you, regardless of whether you're a BMA member or not. But it gives us a way of sort of staying in touch with you. So yeah, even if you don't win, you'll get that guide which sort of breaks down the junior doctor contract. So it's going over things like your pay slip, your annual leave, etc. We negotiated the contract, so we know what should be in it, sort of inside out. So yeah, pretty relevant stuff. Even if you're a med student, you'll still be going on to that contract one day. So yeah, that competition code will be in the top corner while I'm doing my little presentation. So I've only got a few slides and then I'll be done. So feel free to do it while I'm talking. Yeah, so just very briefly from me, I'm sure you're members or you've been a member at some point, so you know a bit about what the BMA does, what we are, and what you sort of get with membership. So it's a little bit of a refresher, and hopefully you might find out something new as well. So essentially, we're the leading trade union professional association for doctors and med students in the UK. So yeah, we look after you, and we're the voice of the profession, representing you individually, locally, and nationally. So on pretty much everything that affects you. So while it's your job to look after patients, it's up to us to sort of try and look after you best we can. So sometimes we get confused with MDU and MPS, so indemnity companies. We're not an indemnity company, so we're not like those guys. We don't deal with patient complaints. We're your union. We're here to look after you, your working conditions, so things like pay, contracts, your professional development, and also your well-being. So you may have heard of our, if you're a junior specifically, you may have heard of our contract checking service, which can save time, potentially quite a bit of money. So probably the key tool for you guys to use. I'm assuming you've all sort of had your contracts at some point. I wouldn't be surprised if some of you haven't seen contracts yet. But yeah, if you get your contract, we'll check it for you within 5 working days compared to the national model that we negotiated back in 2016, and then obviously we renegotiated in 2019. If there are any issues, we can help get them sorted. So it's not always on purpose, but trust can sort of slip in extra things into the contract, or sort of change the wording to say things that are the opposite of what they should say. So this is common stuff that we see. So we just want to make sure your contract is correct and you're getting what you should be. So yeah, if you're a member, you can send your contract in to us, and we'll check it. If there's any issues, we can take it up with the trust. We have people on the ground at every single trust in the UK. So we can pretty much get it rectified straight away. Like, it's very rare that it takes too long. So yeah, 25% of contracts we checked last year were wrong. So 1 in 4. It's just too high a number, and always preference to get it checked by the BMA before you sign it. But if you signed it and it's wrong, it's wrong. Like, it shouldn't have been like that in the first place. So it doesn't matter. We can still get it rectified, so even if it's signed. You can also check if your rote's compliant by using our rote checker. That one you just enter in your hours and whatnot, and it'll flag up to us if it's wrong. And again, we can get in touch. So yeah, just a few figures there. We understand the sort of things that you might face, as you can see the amount of cases and wrote queries and whatnot we've answered. There's not much that we haven't seen before that we can't help with, so always think of us as sort of your first port of call for any issues. Yeah, we can take some of the pressure off you if you feel if you're facing anything you feel you need support with. We have, like I said, we have relationships with pretty much, well, with every trust in the UK, and we have people on the ground at every trust in the UK, so we know who to talk to and do things on your behalf. So yeah, just in terms of other things like learning and development stuff to help, BMA Library has thousands of ebooks and journals plus research services where you can access from anywhere. So this is also for students as well. BMA Library is currently closed, so you can't go there in person at the moment, but everything's sort of moved digitally anyway, so you can access things straight away. Clinical Key is our newest tool, so that's essentially a medical search engine where you can search for conditions, guidelines, sort of drug monographs, and then watch step-by-step procedure videos. You can access that on your phone and laptop, and it'll help you sort of diagnose quicker and dig down into more detail. It also comes as an app as well, so really good tool to have in your pocket. You can also use our clinical, non-clinical learning tools. So you have full access to BMJ Learning, which has over 1,000 clinical, non-clinical modules. It also gets CBD points for every module we do. And yeah, you can print off certificates for everything you do as well. You get weekly subscriptions to BMJ's Power membership as well. So that's delivered every single Friday to the address you got registered with us. If you're not getting it, just make sure we've got the right address for you. And also you can opt out of that and just have the app version. And also we have a series of webinars as well, which you can watch live and on demand. If you're thinking about specialty options already, we've got a tool called Specialty Explorer, and that can help you get a bit of a better picture that suits you best. So that was an online psychometric test, which takes about 20 minutes to complete. Last all sorts of work-life balance questions, then it will give you a detailed report listing top suit specialties according to the answer you've given. Really easy to use and covers all specialties in the UK. Just nearly finished from me. So just moving on to your well-being. If any time you feel like you'd like to speak to someone about your well-being, we have services that are open 24/7, and that's open to everyone, to doctors, med students, whoever. And it doesn't matter if you're a member or not. It's completely free. So yeah, that's a telephone-based service, and we do offer video calls as well if you prefer that. Again, confidential, free of charge, and open to everyone, regardless of whether you're a member or not. So yeah, if you're not currently a member, you can join the BMA and pay nothing for your first month of membership if you use that QR code down there, different one. I could also post that on the chat as well. So yeah, so that's it from me. Just one last chance to enter the competition. One of you over the series of events that I come to will win that £100 Amazon voucher, and yeah, it's just a way for us to stay in touch with you. Yeah, that's it from me. I will let you crack on with the show. Thanks for having me.
Okay, thanks very much, Daniel.
Thank you.
Yeah, really excited. Really excited about that competition. Syra, our finance and surgery lead, is sitting in the room. She has already entered, she tells me. I've posted it to the medal chat so all our viewers can see it, and later I'll post it to the Facebook group. But now I've got to say it's my absolute pleasure to introduce Dr. Syed. He will be doing a talk this evening on fever with rash. It's a very common thing that lots of you will see when working with children. So I can hand over to you. Off you go, Dr. Syed.
Thank you very much. Good evening, everybody. I'm Dr. Syed, pediatric consultant at the moment working in Stoke Mandeville Hospital, Aylesbury. And the topic is very common for pediatric people, those who are dealing in emergency or in their clinics. So basically, although subject is purely pediatric oriented, but it will be very helpful even for all doctors to skill up their general knowledge, because everyone may face a child with fever, rash, or even adult with fever and rash anytime. So this little guideline will help him to be more skillful. So this is the definition of fever. Most people will agree. Increase in body temperature more than 37.5. That means a skin temperature of 37, or core temperature, which is rectal temperature of 38. And this is the definition of rash. It is a visible lesion of the skin due to primary skin disorder or a sign of systemic disease process. And that means anything which is not skin-like is a rash. So rash in a febrile child is something very common, symptom complex for the children attending in GP clinic or in hospital attending emergency departments. So rash may provide the only clue to an underlying infection. So seeing the rash carefully is very, very important. Maybe the hallmark of a contagious disease. So that may be only physical sign where you can judge that there is something serious infectious disease, or maybe an early sign of a life-threatening illness. So rash should not be casually viewed, rather should be seriously viewed. Now, if you look for the causes of rash, it is very simple. There are 5 basic causes. So if you remember 5 fingers of your hand, you can remember what are the 5 groups which can cause rash. Infections, allergy or hypersensitivity, immune-mediated, bleeding disorder, or idiopathic. The differential diagnosis of fever with rash is extremely wide. You can enter hundreds of conditions in differential diagnosis. A precise diagnosis may not be possible on bedside. Through a careful history and physical examination, a working diagnosis can be made in many sick children. Now, this is very crucial to make a working diagnosis for starting early therapy where appropriate and considering isolation where necessary. Now, the approach to diagnosis is simple like any other condition. We go with history. Age is very important because certain age group have more rashes, while adult age group may have less possibility of infectious rashes. Past illness very important. A person had measles before may not have next rash, although look measles-like of measles. Season is relatively important in the sense that measles is more common in winter and rubella more in spring. Then geographical question is very important, that which location this child was and the rash happened. For example, a rash in a tropical country may be simple insect bite. Travel history is equally important, so that can give a clue. And immunization status is very important, that whether the child is fully immunized or not immunized. So history of exposure is very important, and exposure to huge variety of things can cause rash. Exposure to food, water, plants, animal, pets, insects, infected human secretions, and household contacts, domestic cleaning agent, industrial or agriculture products. Medication history is very important because rash may be because of the medication used previously. Now, for drug rash, I will add that a rash may come on the first dose of a medicine given or may come 20 days after the last dose. So we have to keep our mind open for drug rash. That it's not necessary that if a child is using drug for a week and no rash was there, on dates, rash cannot be because of drug. It could be still drug rash. Sexual history is important in teenagers, and immunocompetence is important because immune-compromised children or who on immunosuppressive therapy can develop unexpected rashes because of unexpected infections. The symptoms about the rash are very important because many typical rashes may have a prodromal period of illness. Then general well-being is important. How sick is the child or how well is the child while having rash? Timing of onset of rash in relation to fever is helpful in diagnosis many places. Then distribution and spread of rash is also typical in certain illnesses, and that can give a good clue that what sort of infection we are dealing. Then evolving rash or changing appearance after onset is also very useful. Then itching, pain, and burning of the rash is also important. Although every rash will have little bit irritation, but some rashes are notorious for excessive itching. So that will be a good clinical clue. In physical examination, we have to be very, very thorough. And examination of mucous membrane, conjunctiva, genitalia, lymph node, liver, spleen, neurological examinations, signs of meningeal irritation, joint examination is very important. Complete body surface examination is very important, including scalp for a thorough evaluation of rash. Morphology of lesion is very important. So when we see the rash, we should be able to document what sort of rash it is. Distribution and extent of rash is very important. And then any evolving lesions. I mean, the lesions are of different age groups or different stages of appearance or development. This is very important. Morphology of rash can be described in few terms: macula or a patch or flat rashes. Papules are the raised rashes. Nodule is simply a bigger papule. If it is more than 5 millimeter, it is called nodule. Plaque is a crust on the skin, like eczema plaques. Vesicle is a fluid-filled rash or spot, and bulla is a bigger vesicle, and pustule is a pus-filled vesicle. So if we look at the skin, so this is how a macule will appear. The surface of skin is smooth, exactly. I mean, if you close your eyes and move your hand on this skin, you will not feel the rash. So these are called macular rashes or a patch if it is bigger. Then papules are raised. You will feel a bump. Nodule is a bigger one, and plaque is just a crusted lesion, and vesicles are where you can see that probably there is fluid in it. So this is how you can identify a rash, whether it is macular, papular, plaque, or a vesicle, and then describe the extent of rash and distribution. Now, extensive rash is very helpful in diagnosis. If the person has a fever and rash and there is mucosal and tongue involvement, these 6-7 are the possibility. So that can help you to narrow down your differential diagnosis. So herpes simplex, infectious mononucleosis, measles, varicella, scarlet fever, toxic shock syndrome, Kawasaki disease, hand, foot, and mouth disease. So you think of these if skin and mucosal involvement is there. Palms and sores. In acute meningococcemia, hand, foot, mouth disease, measles, erythema multiforme, Kawasaki disease, toxic shock syndrome, drug rash. These can involve palms and sores. Discomation. So rash after appearance, after few days, can start discomation, mean peeling off the superficial layer of skin. So that is character of these 6-7 diseases: scarlet fever, measles, staphylococcal scalded skin syndrome, toxic shock syndrome, Kawasaki disease, Stevens-Johnson syndrome, drugs hypersensitivity, and toxic epidermal necrolysis. Rash with excessive itching. So although every rash could be a little bit itchy, but these are excessively itchy rashes. In urticaria, in chickenpox, in eczema, in insect bites, scabies, secondary syphilis, and drug rash. And up to 2% of children exposed to different medicine may develop a rash, which are two main types: morbilliform rash, which is like measles-like rash, or urticarial rash. Associated physical signs are very, very important in helping to make a diagnosis. Meningism. So meningism is not common with every rash, but few conditions are associated with that. Number one is acute meningococcemia. It may have signs of meningeal irritation. then enteroviruses, herpes simplex, Lyme disease, secondary syphilis. Associated physical signs, arthritis and arthralgia. So few conditions are associated with pain in the joints or swelling of joints, acute meningococcemia, disseminated gonococcal disease, rubella, parvovirus B19, roseola infantum, Lyme disease, rheumatic fever, Ritter disease, or SLE. Here, joint involvement will be there with rash and fever. Lymphadenopathy. If it is very regional, it could be because of cat scratch. If it is cervical, then three most common conditions are rubella, scarlet fever, and Kawasaki. If it is generalized, it is infectious mononucleosis, secondary syphilis, toxoplasmosis, sarcoidosis. And if it is shown on chest X-ray, it is most likely sarcoidosis. Then pulmonary infiltrates. So if child has respiratory symptom and chest X-ray is done in a child with fever and rash, these conditions could be diagnosed like mycoplasma, varicella zoster, atypical measles, or sarcoidosis. Investigation. So these are the basic investigation we usually do in case of rash. Certainly skin biopsy come in the end, and serology also takes some time. Now diagnosis. So when we see in emergency or in clinic a child with fever and rash, most of the time it is very difficult to make a straightaway diagnosis. Now, is diagnosis important? Many times not very important to make it just at the bedside, but sometimes yes. So what are the conditions where we cannot walk off the bedside without a diagnosis? And these are the conditions: fever with rash in critically sick child. If child is very unwell, we have to make some diagnosis and start some management. Number one is famous meningococcemia. So in meningococcemia, 75% of children have petechial or purpuric rash, but remember, rest may have simply maculopapular or urticarial rash. So if child is very sick or unwell, but rash is urticarial or papular, please don't consider that it is not meningococcemia. It can be still. This is the appearance of meningococcemia, and in advanced stage, it can be so much necrotic. Now, this is a rash of toxic shock syndrome. So usually child present, or a teenager girl may present with high fever and a bluish pink fine rash on the tummy, plus the involvement of palms and sore. So this will be the appearance of toxic shock syndrome. Of course, child will be very sick as well, high fever, very sick, plus the physical signs include this. Now, once you have treated the child and child started recovering, many times initially we couldn't diagnose what is these lesions are. You will see condition like this. This is how it is peeling off, as if some glove is coming from the hand. So this is a very famous pediatric condition called staphylococcal scalded skin syndrome. This is because of toxins of staphylococci, and it appears that somebody has dipped the child in boiling water. There are multiple big blisters, but child is usually not very sick. And this child needs to be treated with antibiotics, and we have to care that as there is a lot of raw skin, there is no secondary infection of the skin.
Dr. Syed, is that painful? Like, is it as painful as it looks?
It's not painful. All the cases I've seen, children were comfortable, but they look very horrible.
But it looks like it's, yeah. Okay.
Big blisters.
Mm.
Because very superficial layers are ballooned up with fluid under it. So possibly the nerves are not much irritated, so no pain. So this is another very critical condition called toxic epidermal necrolysis. So in this condition, usually the child is on long-term therapy with antibiotics or maybe multiple antibiotics. The number of patients I have seen were being treated by osteomyelitis. So here, the skin is split in the middle of epidermis and dermis, and a lot of fluid is leaked out. So child present in site of hypovolemic shock with a bluish papular lesion on the skin. So that is the early stage, possibly sometimes difficult to diagnose. That's why the child is so much hypovolemia, so much tachycardic, so low blood pressure with this rash. So the history is usually the child was being treated with 2-3 antibiotics for the last 2-3 weeks. So once the condition progresses, it becomes more obvious. It starts appearing this. And if you forcibly press the skin, it splits up. So if you see the next slide, it can peel off like this. And this sign is called Nikolsky sign. So when you press the skin with thumb, the epidermis will peel off from dermis, split it totally. And this child needs to be given fluid immediately, and immediately all the medicine should be withdrawn. And we have to make sure that child is not going in acute renal failure. Many of the children end up in acute renal failure because of hypovolemia, because condition is usually presented late. This is Stevens-Johnson syndrome. It can happen usually after medicines, or it can happen from infection also. And if the mucosa is involved, it can cause GI hemorrhage, which is very dangerous. And worst thing is, unfortunately, if conjunctiva are involved, so then there has to be big ward to save the vein and eyes, because conjunctiva can lead to adhesions. This is, you can say, rash of Kawasaki disease, which is also quite common condition. And most important thing is, you look at the eyes, the conjunctiva is quite red and congested, but there is no pus. So that can discriminate. All other conjunctivitis is associated with purulent discharge. So this is aseptic condition. So the conjunctiva will be having no purulent discharge. And then mucosa is involved, palm and soles are involved, and body is involved with the rash. This is acute rheumatic fever. Luckily, we don't see that often, but just for academic interest, I mentioned. So this is the rash of that. This is also rash of acute rheumatic fever, called as erythema marginatum. Now, so these were the life-threatening condition where you have to make a diagnosis. You cannot wait for long investigation to come and dermatologist to help you and all that. Now, there are other conditions which are less life-threatening and can present with fever and rash. And these are the common conditions. So in this, most common reason for the rash is I have put in the last one, so that we are not making this diagnosis first. Okay, this is non-specific rash. That is not a good way. We should consider that non-specific viral illness in the end. In the beginning, we should consider, is it a specific viral infection? Is it a scarlet fever? Is it allergic rash or urticaria rash? Is it a drug rash? Is it erythema multiforme? Or it is Henoch-Schönlein purpura? And if all these list is exhausted, then you may declare non-specific rash if child is very well. So this is rash of scarlet fever, it is called sandpaper rash. So it is a very fine rash, pink fine papular rash. So look like a flushed skin. Only if you are very carefully palpating it, you may find very fine granules on the skin. This is the tongue in scarlet fever called red strawberry tongue. And if there is exudate, it appears like this, it is called white strawberry tongue. This is rash of rubella, little bit out of focus picture, but it is a generalized pink papular rash, and child is usually quite well other than cervical lymphadenopathy. This is a rash of a condition called as slap cheek syndrome. So basically, the cheek look like as if the parents are slapping the child. But if you look at the body, it has a beautiful lacy type of rash. And it is a little bit raised above the surface also. So this should not be mistaken as a mottled appearance, that means shock. So it is basically palpable also. So this is rash of measles. And this is the coplic spot which are there before the skin rash appears. And this is the rash which appears when these coplic spots disappear. So this is a typical rash of measles, and it starts from neck and behind the ears and takes a couple of days to spread up to the legs. So that pattern of progress is very typical in measles. And child is usually very, very sick with measles rash. This is a rash of roseola infantum. Now, this rash is mostly confused with measles rash. If you look at both, appearance is very similar. But I will tell in the end how we can clearly discriminate between the two. This is rash of erythema multiforme that can be because of infection or drug, and they are typical target-like lesions. This is a rash which is very horribly looking, but child is usually very well, Hannock-Schönlein purpura. And this purpura is usually very typical on the extensor surface of arms and buttocks and legs, but it can be so dangerous looking as sometimes. But usually child is very well. This is another rash which is more of academic interest. It is called Giornotti-Crosty syndrome. Now, this rash has typically involvement of cheeks and legs only. There's no much on the trunk. Now, when this rash was initially reported, it was associated with hepatitis B. So many people started believing that it is the hallmark of hepatitis B. Later on, people have reported so many viral infections associated with this rash. So then, possibly it just remained in books as an academic interest only. Right. So all these pictures and all this information may help us to make a diagnosis that whether it is a specific rash and non-specific. Specific means whether it is measles, mumps, rubella, scarlet fever, or any particular condition, we can diagnose from the rash. Now, if we are not able to make a clue, many times it happens that rash doesn't give a clue that what exactly is the underlying diagnosis. So before we surrender and walk off that it is a non-specific rash, I'll give you a clue you can still diagnose. You have to remember this sentence. Really very sick persons must rest. If you remember this, you can still make a diagnosis. And how it can help this way. So these are number of fevers when the rash appears. So if rash is appearing after 1 day of fever, it is either rubella or varicella, chickenpox. If the rash appearing after 2 days of fever, it is scarlet fever. If the rash appearing after 3 days of fever, it is smallpox. Luckily, it is gone. If rash appears after 4 days, it is measles. And if rash appears after 5 days, it is roseola infanta. And remember, I told you that the rash of measles and roseola infantum is same. And it's hard to remember that whether there is 4 day of fever or 5 day of fever. Then you can misdiagnose. But clinically, it is very different. In measles, there is a week of prodromal symptom, running nose, cough, coryza, and then fever starts. And on the 4th day of fever, at the peak of illness, when child is very, very sick, the measles rash appears. While in roseola infantum, child has a fever for 4 or 5 days, fever completely settles, and child is very well, rash appears. So rash appear on a febrile, healthy, recovered child. So many people blame to the medication which was used during that 5 days of illness, some amoxicillin, some distraclor, that possibly it is a drug rash. Actually, it is roseola infantum. So if rash appears after the temperature is settled on a healthy child, it is roseola infantum. So you can make a diagnosis. And these are very common rashes. Roseola infantum is quite common, but you have to be very careful in making a diagnosis. Thank you.
Okay, thank you very much, Dr. Syed. Is there any advice you would give to the audience if they perhaps haven't seen lots of rashes before? You know, maybe if they're quite a junior doctor or a new PA or ANP.
I believe they should have an organized and little disciplined approach. It can help. If they are scared of rashes, then they will not end up in any diagnosis. So little disciplined approach, how sick is the child, what is the distribution of rash, what is the appearance, how many days fever and then rash appeared, and morphology of rash, any pleomorphism, like chickenpox rash is typically pleomorphic. You can see papule, you can see pustule, you can see vesicle, you can see crusted lesions, same patient on any day. So the pleomorphism can help diagnose this is chickenpox, which is not there in other. Then of course, peeling off, skin is a corrector. So every have some associated features, if you keep in mind, that can give you a clue. And if child is very, very unwell, then we have to consider the life-threatening condition.
Okay, perfect. That's really helpful, actually. So, yeah, look at the whole child, see how sick they are, go out and see lots of rashes, and then, like you said, the nice kind of organized, structured approach. So I've got a question from someone that was watching. Judith Harford said, can you recommend any resources for helping to learn more about rashes in peds, or that I can direct colleagues to?
I think all these conditions are discussed in different chapters of books, but particularly in infectious diseases. So they should make themselves little familiar with the rashes, and when the patient comes, try to get a diagnosis and remind themselves that this is the real rash of this condition. So once they start learning, gradually they will get confidence and certainly get some expertise in the rash. So it's all observation and repeated observation.
Okay, thank you. And I will add my own resource as well. DermNet NZ has loads of good high quality pictures of rashes. Though I will say some of the diagnoses on there are quite specialist and niche, but they have very good quality pictures.
Yeah, they should start learning. I also just started learning because everyone was afraid of fever and rash. So then I thought better to learn it rather than staying scared.
No, I think that's very good advice. I know when I see like any sort of derm condition as someone that's quite junior, I am definitely a little bit frightened of it. But I think no, I will take your advice and try and go out, see as many as I can and get that experience to
Getting familiar with rashes and a thorough history and examination, little methodical approach, all can help. Learning briefly about the common conditions, how they present, what are the associated features, all this is quite helpful.
Okay, and then unless there are any other questions coming up, I just want to highlight that I've posted in the chat a link for the feedback. Please do take a couple minutes just to give us some feedback. We want to hear what you think. We like to, see if there's anything we can improve on, or if we're doing good stuff, we want to make sure we carry on doing good stuff. So do fill it out and you will get a certificate to say that you attended. I know that's very good for the doctors, but also any A&Ps and PAs that are building a portfolio. It does show some good interest. The talk will be available both on YouTube and on Medal for catch-up. Normally it takes me about a day or so to upload it. But thank you ever so much, Dr. Syed, for giving up your evening to speak to us all. That was fantastic.
My pleasure. If some people have learned something, it is a great pleasure, because it will help the children who are coming under their care.
Cool. Well, thank you very much. And I will end the live stream there.